Today we'll discuss, there was a mistake in the announcement. So the correct lecture today is retinal vasculitis. So this lecture is based on an important review article that we published years ago, and now it's becoming a standard article about retinal vasculitis, differential diagnosis, which is based on a clinical approach. So, retinal vasculitis is a vision-threatening inflammatory disease that involves retinal vessels. It can occur as a complication of neoplastic disorders, which is very important, complication of infections in association with systemic inflammatory disease, and it can be an isolated idiopathic condition. There is a big list for infectious causes of vasculitis. Have a pointer. The most common bacterial infection is, of course, tuberculosis. Viral etiology, Cytomegalovirus, HIV, varicella zoster, and herpes simplex. Parasitic disorders like toxoplasmosis, rickettsial disorders, it has been reported with Mediterranean spotted fever, Rocky Mountain spotted fever. Neurological disorders, which is very important. Not many people know that multiple sclerosis is an important cause of retinal vasculitis, in addition to Sussex syndrome. Sussex syndrome, which is macroangiopathy of the brain, retina, and cochlea. I remember many years ago, I received a patient from neurology. MRI findings suggested multiple sclerosis, and I examined the patient. He had typical feature for Sussex syndrome. And when I called the neurologist that your patient has Sussex syndrome, he didn't know about it. He was surprised. Then I told him, you have to read about it, because the MRI findings of Sussex syndrome can be very similar to that of multiple sclerosis. Malignancy, we should not ignore malignancies such as ocular lymphoma and acute leukemia. The list of systemic inflammatory disease treated with retinal vasculitis is very huge, but partial disease, sarcoidosis, and systemic lupus erythematosus are the most common. Ocular disorders limited to the eye, frosted branch uveitis, IRVAN or idiopathic retinal vasculitis aneurysms and retinitis, idiopathic recurrent branch retinal arterial occlusion, barzellanitis, and birdshot retinal choroidopathy. In ophthalmology, we are lucky because we can see the retinal vessels with our ophthalmoscopes. We don't need to take a biopsy to examine the retinal vessels. So it is accessible to light visualization. So therefore, the diagnosis of retinal vasculitis, clinical diagnosis, is based on a clinical examination and helped with fundus fluorescein. The hallmark feature of retinal vasculitis is that we cannot tell a case as retinal vasculitis unless we see perivascular inflammatory exudate that will lead to sheathing or cuffing of the affected vessels. This is the classic feature of retinal vasculitis. We should see this. It is not only leakage. You can have leakage in retinal ischemic condition like in diabetic retinopathy or in patients with central retinal vein occlusion, and you can have leakage in patients with IRVAN syndrome. It is not only leakage. It is the perivascular exudates that lead clinically to vascular sheathing or cuffing. In most of the cases, the veins are involved. So in most cases, it is periphlebitis. And in the majority of the patient, the inflammatory infiltrate is in the perivascular area. It is not in the visual wall. So the most right diagnosis is perivasculitis, and the most common is periphlebitis. How about pathology? We have pathological data available for multiple sclerosis. It has been shown pathologically that patients with multiple sclerosis, retinal vasculitis, they have segmental perivenous inflammatory infiltrate composed of lymphocytes and the plasma cells involving the veins, and this is corresponding to the vascular sheathing. So this study told us that the vascular sheathing is corresponding to the perivascular inflammatory infiltrate. I'm going to show you many examples because this is frequently missed. This is a patient with multiple sclerosis. You can see granulomatous anterior segment inflammation. Can we dim the room, please? So as you can see here, this patient is a two-segment examination. The patient had not-on-flat creative precipitates, and this is very common in patients with multiple sclerosis. But look at the characteristic vascular sheathing. This is, when we see this picture, we always ask for MRI with the brain, and in the majority of the patient, the MRI showed the malignant lesion. This is typical vascular sheathing, which is, we described it in our last paper as elongated vascular sheathing. And if you do fluorescein angiography, the leakage is very suggestive. It is not diffuse leakage, it is focal leakage. So this pattern of sheathing in the periphery with focal leakage is highly suggestive for MS. Another patient with not-on-flat KPs, because granulomatous inflammation of the anterior segment is common in patients with multiple sclerosis. And look at the typical vascular sheathing, the elongated vascular sheathing in the periphery. Another patient with more prominent not-on-flat KPs, granulomatous inflammation in the anterior segment, and then the typical vascular sheathing. Another example with focal leakage, demyelinating lesions. Another example of granulomatous anterior segment inflammation in multiple sclerosis, and the vascular sheathing, and with focal leakage. This is also another example. So please don't miss this pattern of vascular sheathing, because this is pathognomonic for multiple sclerosis. And if you do fluorescein angiography, there is focal leakage. And we published a recent paper on clinical findings and outcome of uveitis treated with multiple sclerosis. And the most common finding in this patient was this type of vascular sheathing. We have also pathological data available for sarcoidosis that told us that the vascular sheathing or cuffing that we see in vasculitis associated with multiple sclerosis is due to inflammatory infiltrate composed of epithelioid cells. And this is the example of vascular sheathing or cuffing that we see in patients with multiple sclerosis. This is another example of a patient. You can see a few not-on-flat KPs. This patient had sarcoidosis, optic nerve head swelling in one eye, the other eye more optic nerve swelling. And keep in mind that optic nerve head swelling is common in sarcoidosis. And then you can see the cuffing of vascular sheathing, which is segmental. On fluorescein angiography, it does show only inflammation of the optic nerve, It didn't show any other signs. But it's the ICG which helped us to make the diagnosis. Insulin grain angiography showed many hypofluorescent spots corresponding to granulomas. So the message that I would like to give now is that insulin grain angiography is an imaging modality to study the choroid, because you will not be able to see these granulomas unless you do insulin grain angiography. And there's the other eyes, so many granulomas which are full thickness granulomas. In patient disease, you have also pathology that told us that the vascular sheathing that we see in patients with patient disease is composed of lymphocytic infiltrate. An example of vascular sheathing in a patient with patient disease, of course, when you have vasculitis, you have also intraretinal hemorrhages. And this patient, he had inflammatory branch vein occlusion. Inflammatory branch vein occlusion is highly suggestive for patient disease. Patient disease is the most common cause for inflammatory vein occlusion. And if you do fluorescein angiography, you can see delayed filling of the inferotemporal circulation, confirming the diagnosis of inflammatory branch vein occlusion and also late leakage. And this is the histopathology. This picture we published in our paper that was Professor Inomata from Japan allowed us to include this picture in our review article. Vasculitis, we have also histopathology. The sheathing is corresponding to inflammatory infiltrate composed of lymphocytes. We have also similar histopathology in patients with Berde-Schott chorioretinopathy. The situation is different in patients with systemic vasculitic entities, such as systemic lupus erythematosus, Wagner's granulomatosis, polyarthritis and Church-Strauss syndrome. Also, they are always tell that these patients have vasculitis. It's not correct. There's no inflammation. The vascular occlusion in this patient is due to macrothrombosis. There is no inflammation So it's better to call the vascular disease in patients with systemic lupus erythematosus vasculopathy rather than vasculitis, because intraocular inflammation is not a feature of these diseases. But these diseases, because of the vascular occlusion that tends to affect the retina. If you have occlusion of the retinal arterioles, what do you expect to see in the retina corresponding to occlusion of the retinal arteriole? Convoluted spots. Therefore, in patients with systemic lupus erythematosus and other systemic vasculitis, what you expect to see is many convoluted spots, like in this patient bilateral, this patient occlusion of a pseudoretinal artery, leading to ischemic whitening. Our colleague in Paris, Professor Fouque-Luang, he described for the first time an animal model, primate model of retinal vasculitis. So he immunized the monkeys with human retinal S antigen, and he developed retinal vasculitis exactly the same as we see in humans. And this is from, he personally gave me these pictures. You can see the vascular sheathing and the retinal hemorrhages, retinal edema, and fluorescein angiography showing leakage. This is from another animal with extensive vascular sheathing. These animal models are very important to study retinal vasculitis. In the animal model, the same histopathology that we had inflammation and retinal vasculitis involving mainly the veins with lymphocytic infiltration around the vessels. So it is a perivascular infiltrate. We have also a rat model that was immunized with retinal S antigen showing the same features. So what are the clinical findings? A patient with retinal vasculitis might have vitreous involvement, vitreous cells. Of course, sheathing or coughing is a must, is a hallmark feature of retinal vasculitis. Macular edema is common. Occlusive vasculitis involving the retinal arterioles will show as many convoluted spots. Occlusive vasculitis involving the veins, you will have retinal hemorrhages, edema, and hemorrhagic infarction. So again, to emphasize that to diagnose retinal vasculitis, you have to see clinically the vascular sheathing. Fluorescein angiography is very important in the workup of these patients. Patients with active vasculitis, if you fluorescein angiography will show extensive leakage due to breakdown of the blood-retinal barrier and staining of the blood vessel wall. But the type of leakage can help us to narrow the differential diagnosis. I told you, with MS, we could see only focal leakage. So focal leakage can suggest sarcoidosis or multiple sclerosis. On the other hand, diffuse leakage is seen in patients with Behçet disease or presumed tuberculous vasculitis. If you see diffuse capillary leakage, if you see that each capillary is leaking, think always about Behçet disease or bird-shot choroidopathy. Bird-shot choroidopathy is a disease which is very rare in our region. So this is an example of tuberculous retinal vasculitis. You can see the vascular sheathing, and look at the leakage. It's diffuse vascular leakage. Fluorescein angiography will help also to secure the diagnosis of macular edema. You can have optic disc leakage, but most important, fluorescein angiography will tell us if the vasculitis is occlusive or not, because this is a very important clinical issue. If the vasculitis is occlusive, means that the patient is at high risk to develop neovascularization, fibrous tissue, traction retinal detachment, and vitreous hemorrhage. So during the workup of a patient with vasculitis, we have to look carefully for retinal ischemia. So this is a patient with retinal, this is tuberculous retinal vasculitis. You can see the vascular sheathing, and the fluorescein angiography is telling us this is ischemic. So why it is important? Because if we diagnose the case as ischemic, we have to control the inflammation, and at the same time, we have to do scattered laser foot coagulation applied to the ischemia. I hear sometimes that some people say, no, laser can induce more inflammation. It's not correct. It's not correct. So like this patient, this is occlusive tuberculous severe ischemia in the periphery with already new vessels. So this patient, you need a scattered laser applied to the ischemic retina in addition to medical treatment. The OCT is highly effective to diagnose macular edema, And the angiosity, like this patient with ischemic vasculitis, angiosity can allow us to see the areas of ischemia. Now, to the differential diagnosis of retinal vasculitis will also be helped by, if you look carefully, if the vasculitis is predominant involving veins or arteries. If it is predominant involving veins, we can think about Behçet disease, tuberculosis, sarcoidosis, multiple sclerosis, pathological, and HIV infection. Predominant arterial is seen in patients with acute retinal necrosis, IRVAN, systemic vasculitic entities such as systemic lupus erythematosus. So this lecture is based, as I told you, on the review articles that we published some years ago. And so we based the differential diagnosis, and after a lot of discussion with my colleagues and attending many international meetings, I came with this approach. This is the best approach for differential diagnosis of retinal vasculitis, based on clinical findings. So if you see a patient with cotton wool spots, you should think about, so cotton wool spots, as you said, is microinfarction of the retina due to pericapillary arterial occlusion. So if you see many cotton wool spots in a patient with retinal vasculitis, think about systemic vasculitis, such as systemic lupus erythematosus or bullous nodosa, or microangiopathy of the brain, retina, and cochlea, so SAC syndrome. So many cotton wool spots, you should think about systemic vasculitic entities such as SLA or SAC syndrome. So if you look at systemic lupus erythematosus, this is a patient with bilateral disease, but this was a very aggressive disease. The patient was referred from Jeddah, so was referred to the diagnosis of having retinitis. But this is not retinitis, these are multiple patches of retinal infarctions due to occlusion of retinal arterioles. And in addition, the patient had hemorrhages. So if you do fluorescein angiography, it will show you that there is massive occlusion of the retinal arteriole. The patient, in fact, the vision was very poor because the macula was also involving. And this is another case that we saw recently with Dr. Asma, our medical retinal fellow. So patient with, again, many cotton wool spots. The patient was not diagnosed to have systemic lupus erythematosus. Similarly, as you can see in the previous case, the retinal arterioles are severely occluded and the vision was very poor. So the patient was referred to rheumatology, but they can control the systemic disease, but the vision, she will never regain good vision. This is another patient with a cerebroretinal occlusion. So seeing many cotton wool spots, always think about, and this is bilateral systemic lupus erythematosus. Now, how about SAC syndrome or microangiopathy of the brain, retina, and cochlea? It is a disease of young women, but can affect men. It is a small vessel vasculitis causing microinfarctions of the retina, brain, and cochlea. It has a classic triad of encephalopathy, branch retinal artery occlusion, sensorineural hearing loss. The fluorescein angiography is typical, and I'm going to show, this is the patient that was referred by neurology, and once I saw this cotton wool spots, I realized this could not be multiple sclerosis. So we asked for fluorescein angiography, and then we could see fluorescein angiographic typical findings for SAC. You can see the arterioles are leaking, and then they are occluded. So this is typical, this is a classic fluorescein angiographic feature of SAC, occlusion of retinal arteriole, and the occluded arteriole is leaking on fluorescein angiography. So they changed their diagnosis. And another patient, young female, infarctions, cotton wool spots, and if you do fluorescein, this is in the macula, that you see the occluded arterioles are leaking. So another patient of SAC, cotton wool spots, and then fluorescein angiography, it will show occlusion of the arterioles, and the occluded arterioles are leaking. So it's a lethal disease, so we have to make this the correct diagnosis, and the brain biopsy will show microinfarctions, perivascular inflammatory infiltrate of the small vessels, MRI of the brain, the lesions are similar to that of multiple sclerosis, and if you diagnose this disease, the patient needs immunosuppressive therapy with combining corticosteroids and cyclophosphamide. Now, if you see a patient with retinal vasculitis and the patient had retinal infiltrates, it can be infections, if you rule out infections. zone, there is only one differential diagnosis, which is Behçet disease. So I'm not going to discuss Behçet in detail because we shall give a lecture on Behçet. But if you look here, if you see such retinal infiltrates, with or without hemorrhage, the only differential diagnosis is Behçet disease. If you do fluorescein angiography, there is diffuse leakage involving capillaries. Again, another patient with retinal infiltrates, and you look here at the fluorescein angiography, each capillary is leaking. So diffuse capillary leaking involving the capillaries, diffuse leakage involving the capillaries is highly suggestive for Behçet disease. So I'm showing you many pictures so that you will not miss the case of Behçet. Once you see this retinal infiltrates, this is considered to be the most important sign of a flare-up in a patient with Behçet disease. Another patient, the infiltrates can be also, they can develop in the macula, and this patient will have severe visual impairment. Another patient with the infiltrates, another patient, you can see the infiltrates, and look at the leakage on fluorescein angiography. Retinal vasculitis can be associated with necrotizing retinitis. So this is again differential diagnosis based on clinical findings in the eye. And the necrotizing retinitis can be seen in patients with toxoplasmosis, acute retinal necrosis, CMV retinitis, and human T-cell lymphoma virus type 1, associated uveitis. If we look at toxoplasmosis, it is characterized by focal necrotizing retinitis. Frequently, the patient at presentation, they have anterior segment inflammation, which can be granulomatous with a second rise of interpolation. The patient can have vasculitis, which can be very close to the lesion or even far away from the area of necrotizing retinitis. And the vasculitis can be also occlusive if it involves blood vessels crossing the lesions. So this is an example of necrotizing retinitis due to toxoplasmosis and the vascular sheathing, which is in the periphery away from the lesion. Another case of necrotizing retinitis and then the vascular sheathing. Necrotizing retinitis, and look here with fluorescein angiography, there is occlusion of the blood vessel crossing the lesion. As I said, the patient can have granulomatous inflammation at presentation with multiple fat kidneys and necrotizing retinitis in the retina. Cytomegalovirus is an important cause of retinal vasculitis, and the majority of the patients are manifestation of AIDS. So that you can have cytomegalovirus retinal vasculitis associated with CMV retinitis. Like in this patient with vascular sheathing, and this patient with peripheral necrotizing retinitis due to CMV with vascular sheathing suggesting of what's called first branch meningitis. And this picture was given to me by Professor Nick Jones. It's a patient who is retinal transplant with PCR proving GAN cyclovir resistant CMV retinitis. So it can induce what's called first branch meningitis. Acute retinal necrosis is another condition that can be associated with retinal vasculitis. It is caused by herpes group of viruses. It is a disease of immunocompetent individual, but can affect all immunocompromised individuals. So the patient can have peripheral necrotizing retinitis, and here the vasculitis is made arterial. It is an occlusive type of retinal arteritis. You can see here the necrotizing retinitis in the periphery. It is confluent, and the vasculitis involving retinal arterioles. So, as I said, it is an occlusive type of retinal. Look at this patient, very aggressive necrotizing retinitis, and look at the fluorescein. So, it is an occlusive type. It causes occlusive type of retinal arteritis, and in our experience, many of these patients, unfortunately, even if we give them the maximum antiviral treatment, they progress into rheumatogenic retinal detachment and they require surgery. Like this patient, this is after retinal attachment surgery with silicone oil tamponade. Now, if you, during your examination, if you see that the retinal vasculitis is associated with aneurysmal dilations involving the retinal arterioles, there are only two possibilities: IRVAN, or idiopathic retinal vasculitis aneurysms and retinitis, or sarcoidosis. Sarcoidosis, patients with sarcoidosis, they can have arterial macular aneurysm, mainly in elderly patients, female patients, associated with sarcoidosis, multifocal choroidinitis. So how about IRVAN? Last year I gave a quiz. And IRVAN was one of the questions. And none of the residents outside the university, residents, answered it correctly. So please pay attention to this. It's not common, but you cannot miss it. So IRVAN usually is not associated with systemic abnormalities characterized by bilateral retinal arteritis, aneurysmal dilation of the retinal and optic nerve arterioles, peripheral retinal vascular occlusion, neoretinitis, and uveitis. The visual loss is due to hard exudates involving the macula and peripheral retinal ischemia. So I'll show you examples. So this is a patient. You can see the patient had the classic presentation with a large amount of hard exudates in the peripapillary area and involving the macula. And you can see vascular sheathing here involving the arterioles. IRVAN is a disease which affects the arteriole. On fluorescein angiography, you can see the aneurysmal dilations, which can leak. And the aneurysmal dilation on the optic nerve will leak. So these are the classic features of IRVAN. The other eye is bilateral disease, always bilateral disease. Large amount of hard exudates and aneurysmal dilations of the retinal arterioles. And periphery retinal ischemia. So the patient loses vision from the complication of peripheral ischemia. So the patient needs scattered laser photocoagulation to the peripheral retina. And they lose vision also because of the hard exudates in the macula. The patient was treated with laser photocoagulation, and that resulted in regression of the aneurysmal dilation and also absorption of the hard exudates. I have another patient, and this is a more recent patient. This more recent patient was seen in one of the important hospitals, and the diagnosis was not made. We saw the patient. The patient had huge amount of hard exudates and vascular sheathing. The other eye, same. All the patients present the same. Hard exudates in the peripapillary area. And on fluorescein angiography, you see the aneurysmal dilation and leakage from the aneurysmal dilation on the optic nerve. And I did also optos. So the optos showed nicely the leakage from the aneurysmal dilations. And on ICG, it highlighted much better the aneurysmal dilation of the retinal arterioles and on the optic nerve. So the patient, based on few reports that patients with IRVAN, because the response to immunosuppressive therapy, conventional immunosuppressive is very poor, like steroids, mycophenolate mofetil. So we treated the patient with infliximab, anti-tumor necrosis factor alpha agent, and this is the outcome. The aneurysmal dilation is regressed. This is the fluorescein angiography. And hard exudates resolved. This only 10 months after starting infliximab treatment. So don't miss IRVAN because it is not common, but every now and then a patient like this can present to the emergency room. The other condition, again, I'm basing my lecture on the clinical differential diagnosis, frosted branch angiitis. Why it is called frosted branch angiitis? Because when you have, like in winter, the tree branches are frosted, so this will be similar to what we see, extensive vascular sheathing involving the veins, resembling frosted tree branches. So, but this condition can be idiopathic, meaning that the workup is completely negative. But before you make a diagnosis of idiopathic frosted branch angiitis, you have to look carefully to rule out lymphoma or leukemia. And I'm going to show you a patient, a clinical case, that lymphoma or leukemia can present like this. You have to rule out conditions such as systemic lupus erythematosus, Crohn's disease, toxoplasmosis, human T-cell lymphoma virus type 1 infection, AIDS. I showed you pictures with CMV retinitis in patient with AIDS, or even immunosuppressed after kidney transplantation. So all this condition can produce the picture of first branch meningitis. After you rule out this condition, you have to think about idiopathic in young people. And recently, my colleague, Dr. Belushi, he admitted one patient with first branch meningitis after COVID-19 infection. In fact, as you can see here, extensive vascular sheathing. In fact, I reviewed 2 papers to ocular immunology and inflammation. One paper was describing 2 patients with first branch meningitis after COVID infection, and the third patient was from ocular infection and inflammation. They described also another case. So it seems that this condition, first branch meningitis, can occur as a complication of COVID-19 infection. So retinal ischemia is very important issue in retinal vasculitis. As I said, the patient can lose vision because of retinal ischemia, neovascularization, that lead to neovascularization, vitreous hemorrhage, and traction retinal detachment. So it's very important in the workup of a patient with retinal vasculitis to look carefully to the peripheral retina to rule out retinal ischemia. And the most common cause of aggressive retinal ischemia due to vasculitis is tuberculosis. This is a disease that can lead to severe damage of the retinal circulation. And Behçet disease is not as common, and multiple sclerosis, sarcoidosis is a rare cause. So tuberculosis will cause retinal periphlebitis with a marked tendency to peripheral retinal capillary closure leading to new vessel formation. This is an example of a patient with presumed tubercular vasculitis. Again, sheathing is very important. And patients have strangle positive BB disc test, and you can also do ECRA test to confirm the diagnosis. So the management, we summarize the management of tuberculous vasculitis in a paper published in 2002, and that if the patient had active vasculitis means that the patient had active vascular sheathing, you need a medical treatment in the form of full anti-tuberculous treatment for 9 months combined with systemic corticosteroids. If the patient had, in addition, ischemia, so in addition to medical treatment, you need to add scattered laser fluid coagulation. If the patient presents with bleeding, then you need to do early vitrectomy, because delaying the vitrectomy will make the surgery very complicated. So this is a patient with tuberculosis with diffuse leakage. So this is a case of extensive vascular sheathing. And I remember the resident who saw the patient in the emergency room, he thought about branch retinal vein occlusion. If this branch vein occlusion, so this should be inflammatory vein occlusion. And with intraretinal hemorrhage, so the vascular sheathing and severe ischemia. So this is an example of a patient who needs scatter laser in addition to medical treatment. So the patient can present with pre-retinal hemorrhage. And here you can see clearly that neovascularization in the periphery with peripheral ischemia, and fluorescein angiography will confirm the presence of ischemia, and then the scatter laser, that you don't need to do full PRP, you only apply scatter laser in the ischemic retina. So this is an example of a patient after laser and medical treatment. Patient can present with traction detachment, and they need vitrectomy, and ischemia can lead to also rubeous iritis. So this is a blinding disease. Behçet disease can cause ischemia, like in this patient, but not as aggressive as tuberculosis. This is another patient with Behçet. Now, if we see patient with inflammatory retinal vein occlusion, your first differential diagnosis should be Behçet disease. So how would you call the patient to have inflammatory vein occlusion. If you see vein occlusion with vascular sheathing, so this is inflammatory vein occlusion, as you can see. There is delayed filling of the infratemporal circulation, like this patient. This is a patient who had collateral temporal to the macula. All these patients had Behçet disease. This is a patient who had central retinal vein occlusion, and it was inflammatory because there is vascular sheathing. And the patient responded nicely to anti-alpha agent. Occlusive retinal vasculitis can be seen in multiple sclerosis. It's not common. But we have seen several patients with multiple sclerosis. This patient had rhabdosis, iris presentation, as you can, had glaucoma surgery, and fluoroscintigraphy showed retinal ischemia. We applied a scatter laser foot coagulation to this eye, and this is another patient with retinal ischemia, another patient with retinal ischemia. So we published this for cases because it's not common to have occlusive retinal vasculitis in patients with multiple sclerosis. Now, this is the last clinical case, malignancy. Do you agree with me that this picture is similar to that of frost branchiangiitis? But the vascular sheathing was due to leukemic infiltrate. So before we make a diagnosis of idiopathic frost branchiangiitis, we have to rule out malignant conditions such as leukemia. So the diagnostic evaluation of a patient with retinal vasculitis, usually it is a multidisciplinary approach. Usually, like the patient with SLE was referred to rheumatology. So we treat these patients in consultation with rheumatologists. We have to discriminate between infectious or non-infectious etiology. It's very important. In a patient with TB, if you give the patient only immunosuppressive therapy or anti-TNF-alpha agent, then you will have a disaster. But in a patient with TB, you can combine full anti-TB treatment with systemic corticosteroids for a short time. So specific antimicrobial therapy is needed for infectious diseases. Because immunosuppressive agents may be useful in non-infectious disorders, but contraindicated in infectious diseases without a specific antimicrobial coverage. Malignancy must be ruled out, as we discussed. So the diagnostic evaluation should be based on a differential diagnosis derived from detailed history, review of systems, and physical examination. If the medical history, review of systems, or ocular examination suggests an underlying systemic disease, then diagnostic workup should be tailored for the disease. We never do for investigation. I know that some colleagues, they have a big list of workup, lab studies, anti-nuclear antibody, anti-DNA, syphilis, Trojan, and so on, rheumatoid factor even, and this is confusing. You should tailor your workup based on good differential diagnosis. In fact, in my practice, I always examine the patient first. And then after examining the patient, I have an idea about what's going on. Then I ask specific questions to the patient. If there's no signs or symptoms suggestive of an associated disease, then the workup should be limited to fluoroscintigraphy, CBC, El-Asrar, blood chemistry, urine analysis, BBD skin test, and IGRA test, syphilis serology, and HIV serology, and chest X-ray. So what are the complications of retinal vasculitis? Cystoid macular edema is a major complication, but it can be always reversed. So the visual loss due to inflammation, by controlling the inflammation and the resolution of edema, the visual outcome is good. But if the macula is ischemic, like this patient I showed you with systemic lupus erythematosus, the visual prognosis is poor. Patients can have peripheral capillary closure, and mostly with patients with tuberculosis, so occlusive retinal vasculitis. Vascular occlusion and the ischemia can lead to proliferative disease. As I said, new visits, fibrovascular proliferation, vitreous hemorrhage, and traction retinal detachment. Therefore, if you make the diagnosis of occlusive retinal vasculitis, you have to give the patient scatter resistant coagulation, in addition, of course, to immunosuppressive therapy. Inflammatory branch vein occlusion is associated with Behçet disease. So, seeing inflammatory branch of vein occlusion, you have to think always about Behçet disease. Retinal arterial occlusion, think about systemic lupus erythematosus and Wagner's dermatosis, other systemic vasculitis. So in conclusion, retinal vasculitis is not only vision-threatening disease, but could be first sign of a lethal systemic disease. Prompt diagnosis and institution of appropriate therapy will help to control ocular disease and systemic disease. Thorough history review of systems, physical examination are essential. A multidisciplinary team approach is essential in evaluation and treatment. Diagnostic evaluation should be focused, guided by history, ophthalmic and physical examination. Thank you very much for your attention. Any question?
I have a question regarding Susak syndrome. If you have a patient with underlying suggestive of MS lesion and FFA is within normal, and history of sensory hearing loss.
I cannot hear you well. Do you have a microphone?
So my question is about FFA findings in Susak syndrome. You mentioned leakage as a sign in Susak syndrome.
So Susak syndrome on fluorescein angiography is characterized by arteriolar occlusion, and at the site of the occlusion, this is classic feature of Susak syndrome. There is leakage on fluorescein angiography.
Yeah. So if you have this,
you will never see this in multiple sclerosis.
My question is, can you have normal FFA in patient with like history of Susak? This is young woman, unilateral hearing loss, and encephalopathy. Would you still see leakage in FFA if she had like an attack?
Was she treated?
No.
So if the patient is not treated, so the fluorescein angiography findings should persist.
So we still have leakage and occlusion.
Thank you very much for your nice lecture. But my question is, it's from a physician that is not doing retina. But I think with your experience on diagnosing and treating vasculitis, what makes that disease take this pathology while the other take other pathology? One is affecting veins, one is affecting arterioles, one causes necrosis, one does not cause necrosis.
This is I understand, but this is related to the inciting agent. Like, for example, sarcoidosis will affect mainly veins, and mainly arteries.
Why? What's the reason?
Leakage. Behçet is a fulminating infection, so all capillaries are leaking. MS, the inflammation is milder, so the leakage is focal. Sarcoidosis also is a milder inflammation. Tuberculosis is aggressive inflammation, so the leakage is more. Depends on the type of the inflammation.
Because still we are, I'm speaking about a resident level, or our level that are not performing retinal practice and so on. If I exclude the infectious cause of vasculitis, the others will be the same. Mainly, the treatment is the same. So, but we need something that to help us when because patient comes to the clinic, I don't know what's the diagnosis, but I have to go by history.
No. The clinical findings are highly suggestive. Like the patient with SLE, the patient will never cause this. SLE. The patient will have a lot of infarctions. This is not a feature of Behçet disease. A patient with necrotizing retinitis focal due to toxin. This is typical situation. acute retinal necrosis, necrotizing retinitis in the periphery. It's totally different.
So that we can categorize the disease.
That's why I give this lecture based on a clinical approach diagnosis.
It's nice.
Based on what are the clinical findings. And if you see these clinical findings, how would you make the differential diagnosis? For example, Irfan. There's nothing like Irfan.
Maybe my message is not clear. What makes us make it easy that we know that this pathogenesis will cause these things? The other thing, the other diseases, because this is the pathogenesis, they will not cause so and so. So it will be easier for the physician to reach diagnosis.
Diagnosis is reached by clinical examination.
It's a dilemma.
Thank you, Prof. Just I have a question in patients with ARN. So, patients with acute retinal necrosis.
Okay.
So, if they present with, usually they present with peripheral ischemia due to this diffuse retinal necrosis. So,
the ischemia is not due to necrosis.
The
ischemia
arthritis
is due to occlusive arthritis.
Yes.
I showed one good example for this.
So my question is, you usually do scatter laser photocoagulation for those, isn't it?
You're talking about prophylactic laser.
Yes.
You know, that was a heavy discussion in audio-vitis course that I shared here. Do we need to do prophylactic, let's put a barrage of laser at the border between the necrotizing retinitis area and the healthy retina? The answer was that in many of these patients, the media is not clear because they have severe vitritis. And there is no proof that this prophylactic laser will work, that will stop retinal detachment. So the conclusion of most of the experts in the field of vitritis is that you should not do this. You should not do this. But we know that I personally operated recently, in the last 2 years, 6 patients who had rhegmatogenous retinal detachment as a complication of acute retinal necrosis. I should tell that the surgery, if it is done properly, the outcome is good, but it is really very irritating. Even I discussed this during the Retinal, we had uveitis course last year, Retinal, with my colleagues, and they said, okay, perhaps you might need to treat the patient more aggressively. I cannot treat them more aggressive than this. We give intravenous acyclovir. We give intraocular injection of ganciclovir, at least 4 doses. But despite this, I have one patient who is a physician. He was discharged with 20/20 vision, but 3 months later, he came with retinal detachment. Another patient, an elderly man, after 3 years, he presented with the retinal detachment is a common complication of acute retinal necrosis. Of course, also for Cytomegalovirus retinitis.
And those 6 patients you operated, they were not lasered, isn't it?
No, I never do laser.
Okay.
Thank you.
Shukran.